All right, today we're talking about the musculoskeletal system. This system gives your body its shape. It holds your organs in place. It's a very important support structure for your skeleton and your bones. It also includes connective tissue to help keep you supported and help keep you moving. It also helps you create new blood cells to keep you healthy. So the skeletal system has several jobs. Okay, it's going to give your body shape by supporting the weight of your body. It's also the anchor for the tissue that connects to it. It helps you move. Your joints and your connective tissue and muscle all work together. It protects your organ by having this built-in suit of armor for the organs throughout your body. Your skull protects your brains. Your rib protects your heart and lungs, and the vertebrae in your spine keep your spinal cord safe. You also produce new red blood cells and white red blood cells from the bone marrow, and it helps store minerals in your body like calcium and vitamin D. Now, this system is composed of bones, muscles, joints, but also cartilage, ligaments, and tendons. The bones are the body's main form of structural support. We have about 206 of them. The muscles are these tightly woven, stretchy fibers. You have about 600 of them, and they help you do everything from running, walking, jumping, to breathing and digesting food. And joints is any place where two bones meet, and it contains some or all of the pieces that we talked about. Cartilage is a strong, flexible tissue. It sort of acts like a shock absorber in the joints throughout the body. The ligaments are the tissue that connect bones to other bones, and tendons are the cords that connect the muscle to the bone. There are 206 bones. These make up the axial skeleton of the head and the trunk, and the appendicular skeleton of the extremities, the shoulders, and the hips. The bones themselves are composed of osseous tissue, and they can be divided into two types. Compact bone, which is hard and dense and makes up the shaft and the outer layers, and spongy bone, which has these little spaces in it. It makes up the ends and the center of the bone. The bone tissue is formed by cells called osteoblasts and broken down by cells called osteoclasts. The bones themselves have red marrow that produces blood cells, and yellow marrow composed mostly of fat. The periosteum covers the bones. It contains the osteoclasts and the blood vessels that provide nourishment and formation of the new bone tissue. The bone shapes can vary and include short bones like carpals, long bones like the humerus and the femur, flat bones like the sternum and the ribs, and bones with an irregular shape like we find in the hips and the vertebrae. Skeletal muscle actually accounts for about 30 to 40% of your total body mass. These muscles connect to your bones and allow you to perform a wide range of movement and function. They are voluntary, meaning you control how and when they work. There are three types of muscle in your body. Skeletal muscle, which are voluntary muscles, meaning you control how and when they move and work. The nerves in your somatic nervous system send signals to these muscles to make them function. If you reach for a book on a shelf, you're using that skeletal muscle in your neck, arm, and shoulder. Cardiac muscles are only in your heart. They help your heart pump blood throughout the body. They're involuntary muscles that your autonomic nervous system controls, so they work and you don't even have to think about it. Smooth muscle makes up your organs, your blood vessels, your digestive tract, your skin, and other areas. Smooth muscles are involuntary as well, so your autonomic nervous system controls them. Example, muscles in your urinary system that help you get rid of waste and toxins are part of that smooth involuntary muscle. Now, the skeletal muscles are a vital part of your musculoskeletal system. They serve a variety of functions, including to help you chew and swallow, to expand and contract your chest cavity when you inhale and exhale, to help you maintain body posture, to move the bones in different parts of your body, to protect the joints and hold them in place. The musculoskeletal system is made up of 650 skeletal voluntary muscles under conscious control and made up of long muscle fibers, fasciculiculi, arranged together in bundles joined by connective tissue. The skeletal muscle attaches to the bones by the way of strong fibrous cords called tendons. These muscles help with posture, produce body heat, and allow the body to move. The skeletal muscle movements include the following: abduction, moving away from the midline of the body; adduction, moving toward the midline of the body; circumduction, moving in a circular motion; inversion, moving inward; eversion, moving outward; extension, straightening the extremity at the joint and increasing the angle of the joint; hyperextension, joint bends greater than 180 degrees; pronation, turning or facing downward; supination, turning or facing upward; flexion, bending the extremity at the joint and decreasing the angle of the joint; dorsiflexion, where the toes are drawn upward towards the ankle; plantar flexion, where the toes point away from the ankle. Protraction is moving forward. Retraction is moving backward. Rotation is turning of a bone on its own long axis. Which skeletal muscle movement means to move forward? Protraction means moving forward. Abduction is moving away from the midline of the body. Bending the extremity at the joint and decreasing the angle of the joint is known as flexion, and moving outward is known as eversion. Then we also have internal rotation, which is turning the bone towards the center of the body, and external rotation, which is turning of the bone away from the center of the body. So the joint or the articulation, this is the place where the two bones meet. And joints can provide a variety of range of motion for the body parts and may be classified as fibrous, cartilaginous, or synovial. The fibrous joints are like the sutures between the skull bones, and these are joined by fibrous connective tissue and are immobile. Cartilaginous joints that are found between the vertebrae, are joined by cartilage. And then synovial joints that are found in the shoulders, wrists, hips, knees, and ankles, contain a space between the bone filled with synovial fluid that allows for sliding movement at the end of the bone. Bones in the synovial joints are joined by ligaments, which are strong, dense bands of fibrous connective tissue. The synovial joints are enclosed by a fibrous capsule made of connective tissue and then connected to the periosteum of the bone. Articular cartilage smooths and protects the bones that articulate with each other. Some synovial joints also have bursae. These are small sacs filled with synovial fluid that help cushion the joint. A good tip to remember: ligaments connect bone to bone, and tendons connect bone to muscle. The articulation between the temporal bone and the mandible help with the motion. It helps open and close the mouth, project and retract the jaw, and move the jaw from side to side. The articulation between the ulna and the radio of the lower arm and the humerus of the upper arm at the elbow contain a synovial membrane and several bursae. This helps with flexion and extension of the forearm, supination, and pronation of the forearm. Sternoclavicular. The junction between the manubrium of the sternum and the clavicle has no obvious movement. At the shoulder, there is articulation of the head of the humerus in the glenoid cavity of the scapula. The acromioclavicular joint includes the clavicle and the acromion process of the scapula. It contains the subacromial and subscapular bursae. It allows for flexion and extension, abduction and adduction, circumduction, rotation, internal and external. Articulation between the distal radius, ulnar bone, carpals, and metacarpals helps with the movement of the wrist, the fingers, and the thumb. This area contains ligaments and is lined with the synovial membrane. It allows for the following movement of the wrist: flexion, extension, hyperextension, adduction, radial, and ulnar deviation. It allows for the following movement of the fingers: flexion, extension, hyperextension, abduction, and circumduction. And for the thumb, it allows flexion, extension, and opposition. We also have the vertebrae. There are 33 bones, 7 concave-shaped cervical in the C area, 12 convex-shaped thoracic T in the T area, 5 concave-shaped lumbar in the L area, 5 sacral in the S area, and 3 to 4 coccygeal connected in a vertical column. The bones are cushioned here by elastic fibrocartilaginous plates or intervertebral discs. These provide flexibility and posture to the spine. Paravertebral muscles are positioned on both sides of the vertebrae, and these assist with flexion, hyperextension, lateral bending, and rotation. At the hip, there is articulation between the head of the femur and the acetabulum. It contains a fibrous capsule. This allows for the following motion: flexion with the knee flexed and with the knee extended, extension and hyperextension, circumduction, rotation internal and external, abduction and adduction. At the knee, we have articulation of the femur, the tibia, and the patella. This contains fibrocartilaginous discs, medial and lateral menisci, and many bursae, and it allows the motion of flexion and extension. And then in the ankle and the foot, we have articulation between the talus, which is the large posterior foot tarsal, the tibia, and the fibula. The talus also articulates with the navicular bones. The heel, the calcaneus bone, is connected to the tibia and fibula by ligaments, and this creates the following motion. The ankle is able to do plantar flexion and dorsiflexion. The foot is able to provide movements of inversion and eversion, and the toes are able to achieve flexion, extension, abduction, and adduction. There are several biological variations in the bones and the muscles, so just look in your book. There is a list of them, but examples include, like in black people, frontal bones are typically thicker. The parietal bones are going to be thicker in whites. There's some ethnic differences also in the lengths of the radius and the ulna. Some are of equal length, and some have one or the other that are longer. Most people have 24 vertebrae, but some African American females have 24, and Eskimos, Native American men, may have 25. We also see a little bit of difference here in the osteoporosis related fractures, okay, and the number of men versus women that present with osteoporosis. So we have about 26% of women and 19.1% of men. Part of the variations could be related to some of these other factors here. We see that with Asians, about 80 to 95% of them report being lactose intolerant, and so they have limited exposure to milk products or milk, in anything at all because of that. All right, and then some African Americans have large gluteal prominences. This tends to look like lumbar lordosis. And then because some of the ethnic groups like the Swedes and the Chinese tend to have unequal lengths of their ulna and radius. All right, some things that we're going to take into consideration of the older adult. One, they start to lose the density of the bones as they age. This puts them at a higher risk for fracture. And as we see at the top with the osteoporosis, this affects millions of people worldwide. And it tells you that 1 in 3 women and 1 in 5 men will have a fractured bone because of this osteoporosis. Also, we have to look at other potentially causes that could cause joint stiffening other than arthritis. Sometimes arthritis is misdiagnosed in the older adult. So you want to look at any sort of vaccinations that they might have gotten, specifically polio and tetanus, whooping cough, diphtheria. So you want to look at those because there could be some other causes. Also, we know that with the older adult that osteoporosis is more common because the bone reabsorption increases, calcium absorption decreases, and we have a decrease in the production of the osteoblasts, which helps the bone regenerate. Some positions for these clients also may be uncomfortable due to a decrease in their ability to be flexible. All right, so we'll see slower movements in them. This is due to the reduction in the elasticity, so things aren't as elastic as they used to be. Some may have a problem with knowing where they are in space. Okay, so their sense of position in space may contribute to them falling because they might not understand exactly where they are. Kyphosis is common, so this is when they have a curvature in the back and they look sort of like a hunchback, and that can also cause some respiratory issues. Also, don't insist on the client touching the toes when bending forward unless they're comfortable with the movement. Some may have a bow-legged appearance due to the osteoporosis and the decreased muscle control, wear and tear on the knees and the body itself, causing some problems in those synovial areas and in those areas where the knees are supposed to glide. So some of that can wear down and cause the legs to bow out. You might want to do a risk for falling backwards test here, known as a nudge test, where you put your arms around the client and you give them a little nudge on the sternum. And if they start to fall backwards, they could have some kind of issue like Parkinson's or something else going on there. Is the following statement true or false? Decreased estrogen levels after menopause increase the risk for osteoporosis. And that statement is actually true. Okay, decreased estrogen levels are going to increase the risk. All right, decrease the bone mass density and increase the risk for osteoporosis. So next, you're going to ask them about any concerns that they currently have about their present condition. So any recent weight gain that might affect their body, strain on the musculoskeletal system, difficulty chewing with tenderness or pain that might indicate some sort of issue with the TMJ, any joint, muscle, or bone pain. If they have it, what's it feel like? Where's it at? When did it start? How long does it last? Any limitation in the movement, stiffness, swelling, those kind of things. Do they have any past problems, any injuries, anything that's happened to the joint or the muscles? If so, what kind of treatment was given? Any after effects from the injury or the problem? Any sort of surgeries? Now we're going into personal health history. That's all personal health history. What was their last tetanus and polio immunizations? Also, any diagnosis of diabetes, sickle cell anemia, systemic lupus erythematosus, or osteoporosis, because this can put them at risk for other issues with the musculoskeletal system and the nerves in the body. And for middle-aged women, have they started menopause? Are they taking any estrogen or hormone replacement therapy? Because the menopause itself, because of the decrease in the estrogen levels, can cause development of osteoporosis and a decrease in the density of the bone mass. And then you're looking at family history. So any family history of rheumatoid arthritis, gout, osteoporosis, activities that they engage in to promote the health of the muscles in the bones, like exercise, diet, weight reduction, any medications that they're taking, because medications like steroids can deplete bone mass and contribute to osteoporosis. Some reactions to certain drugs like statins can cause rhabdomyosis, which is muscle weakness and soreness. Also, like diuretics can alter your electrolyte levels, causing muscle weakness. So all these things can play a part. Do they smoke? This can increase the risk of osteoporosis. Excessive alcohol or caffeine can increase their risk. We also need to make sure they have adequate protein in the diet. They also should be drinking milk or have, milk products if they can tolerate them, or calcium supplements, vitamin D through sun exposure, dietary sources, and this is going to be required to help absorb that calcium. So recommendations are usually between 400 units and 1,000 units a day, depending on the age. The safe upper limit for vitamin D is 4,000 international units a day for most adults. And then a diet high in purine or those meats like liver, sardines, and alcohol can trigger something called gouty arthritis. Ask them about their day, how much time they spend in the sunlight, any sort of exercise, their occupation, again, heavy lifting, exposure to heavy lifting or consistent repetitive hand movements can cause damage. So the heavy lifting to the back if they're not following the body mechanics, and then the repetitive wrist and hand can contribute to carpal tunnel. Ask them about their posture, their shoes. If they have any difficulty performing their ADLs. How has the musculoskeletal problems contributed to socialization, sexual activity? Did they look at themselves differently? Again, now we're in lifestyle practices. Did they look at themselves differently after they had the injury? Is their life different since they had the injury? So when we look at the physical assessment, we're talking about the posture, the gait, the bone structure, the muscle strength, the joint mobility, as well as their ability to perform ADLs. General routine screening. So whenever people are coming in, we're just looking at the gait and the posture. We're looking for the symmetry, the color, the muscle strength, the range of motions. We're looking at the joints, the muscles, the extremities. We're palpating them. We're testing the muscle strength. We're looking at that range of motion. We're comparing one side to the other. We're performing those tests for carpal tunnel syndrome. And we're looking at the bulge, the ballottement, and the McMurray knee test, which we'll talk about all those as we move on. Okay, so all those things that we're looking at. We're going to measure that range of motion. We're going to use the goniometer, And we'll measure the TMJ, the cervical and the lumbar spine, the shoulders, the elbows, the wrists, the fingers, the hips, the knees, the ankles, and the toes. We're also going to palpate the anatomic snuff box. Now, this is an area on the back of your hand. So if you hold your hand up so that you can see your fingernails, you fan your fingers all the way out, and you just run your finger like right from the middle of your nail bed down. You should see like a little triangle or a little indentation there as it runs along that nerve line, and that is called your anatomic snuff box. And if there was a problem there, that could indicate a scaphoid fracture. So you might see that in someone who fell down and landed flat on their hands. We're also testing for carpal tunnel syndrome, thumb weakness, and the flick signal. Now, the flick signal is when they flick their hand back and forth, and they do this trying to decrease pain or decrease the numbness and the paresthesia in the hand if they have carpal tunnel syndrome. We'll also do a squeeze test of the hand and the foot. So squeezing this hand and this foot, okay, is going to help tell us if the person has rheumatoid arthritis. It can tell us about that. Measure the leg length. So we want to see, are the legs equally long? The bulge test. So what the bulge test tells us about is whether or not there is fluid there. So the bulge test is done if there's swelling present. You would perform it to determine if the swelling is due to the accumulation of fluid or soft tissue swelling, and it helps detect small amounts of fluid in the knee. This is done with the client in the supine position using the ball of your hand to stroke the medial side of the knee upward 3 to 4 times to displace any accumulated fluid that might be there. The ballottement test helps detect large amounts of fluid in the knee. This is done with the client in the supine position, and you're pressing your non-dominant thumb and index finger on each side of the patella. That would displace fluid in the suprapatellar bursa, which is located between the femur and the patella. So if you felt like a wave of fluid or a click, then that would be positive, and that would tell you that there are large amounts of joint effusion occurring here. This can happen whenever someone has a meniscal tear. And then the straight leg raising test, the Lessig. This is done, and this can actually determine if someone has like a issue with their back. So that would be figure 2426 in your book. And so with the client lying on the back and both legs flat and extended, you would support and raise one leg, keeping it straight while the other leg is flat. And that would just happen until you get up to where the pain is, and then you would dorsiflex the foot, and that would stretch the nerve over the disc. All right, so it should not be painful. However, it would be in someone that has a herniated disc. So the physical assessment of the musculoskeletal system provides data about the client's posture, gait, bone structure, muscle strength, joint mobility, and ability to perform ADLs. So you'll have to inspect and palpate the joints, the muscles, the bones, test the range of motion, and assess the muscle strength. You're going to need to prepare the client. So you want to make sure that you have a room at comfortable temperature, that you adequately drape the client, only exposing the areas you need to assess. Explain the procedure to the client, and then demonstrate any sort of movement that you want the client to do with the various body parts, and provide verbal directions as well. You'll also need a tape measure, a goniometer, and a skin marking pen. So those are all here. A tape measure, a goniometer, and a skin marking pen. All right, the goniometer is going to help you to measure the range of motion. The tape measure will help you measure different parts like the legs, and then you can mark the areas of the skin if you need to for one reason or another. All right, again, physical assessment would include observing the gait and posture, inspecting those joints and muscles and extremity for size and symmetry and color, palpating the joints and the muscles and the extremities for tenderness, edema, heat, nodules, or crepitus, testing that muscle strength and range of motion of the joints, comparing the findings bilaterally, performing any tests necessary for carpal tunnel, the bulge, the ballottement, and the McMurray knee test. Now, we still didn't talk about the McMurray, but we will. So as we're looking at posture and gait, we're going to measure that range of motion of all those areas, the TMJ, the cervical, lumbar spine, the elbows, wrists, fingers, shoulders, hips, knees, ankles, and toes. We're also looking at the same areas, okay, the TMJ, the sternoclavicular joint, the cervical, thoracic, and lumbar spine, the shoulders, arms, elbows, wrists, hands, fingers, hips, knees, ankles, and feet, for symmetry, color, and mobility, and we're going to palpate that anatomic snuff box. We'll also look for things like tenderness, heat, swelling, nodules. Again, all those same areas. We're testing for the carpal tunnel, for the thumb weakness, for the flick signal, for that squeeze test, the leg length, the bulge test, the ballottement test, and that straight leg raising or the Lassie test. Again, all these areas we're going over and we're inspecting, we're palpating. We're going to palpate those spinous areas of the back, those spinous processes and those vertebral muscles. We're also going to inspect and palpate. We're going to test the lateral bending. We're going to look at the rotation, the range of motion of the lumbar spine. We're testing for back and leg pain, and we're measuring the leg length. So for sternoclavicular, we want to make sure it's midline, that it has the proper color, there's no swelling, no masses, and there shouldn't be any tenderness or pain. With the cervical, thoracic, and lumbar curves, we're looking at them from side to side and behind. We want to make sure that we have the gown positioned so that we can adequately see the spine. We're looking for any asymmetry, any height differences in the shoulder, the iliac crest, and the buttock creases. Everything should be symmetrical. In the older client, you might see some kyphosis here. So that's what you're looking for also. Those spinous processes and the paravertebral muscles on both sides of the spine, we're checking those for tenderness and pain. They should be well developed, firm, smooth, non-tender, no muscle spasms. If someone does have a compression, fracture, or a muscle strain, this can cause pain in that area. Test the range of motion of the cervical spine. Flexion of the cervical spine should be 45 degrees. Extension also 45 degrees. So cervical strain is the most common cause of neck pain. So you're asking the client to touch the chin to the chest, flexion, and then look up at the ceiling and hyperextension. And you're checking both of those areas of range of motion to see if they're able to do that. Again, pain in that area could be indicative of some sort of cervical disc problem. Also, any impaired range of motion or neck pain that's associated with fever, chills, and headaches could be indicative of a serious infection like meningitis. Okay, we talked earlier about the shoulders, arms, and the elbows and what we would be looking for in here. Again, we're inspecting, we're making sure the range of motion is correct, that we don't have any swelling, any deformities, any redness. that it looks the same on both sides. And we're looking at the wrists, we're looking at the size, the shape, the symmetry. We're looking for any tenderness, any nodules. They should be free of those. We also here may do that squeeze test again, looking for any sort of rheumatoid arthritis or psoriatic arthritis of the hand. So we squeeze the hand across the knuckles and the joints. This is in page 547, figure 2418. This also shows you how to palpate the anatomic snuff box, which is that hollow area or that triangular area we talked about near the thumb. Okay, figure 2419 on page 547 in your book. And then with the wrists, okay, we're looking at the ability for it to move, be flexible, inward, outward, and we're repeating the maneuvers against resistance, flexion, and extension we're looking at here. The Fallon test for carpal tunnel. So we would have the client place the backs of both hands against each other while flexing the wrist at a 90-degree angle with the fingers pointed downward. This figure is in your book, 2421. And the client would hold that position for 60 seconds. So here we're checking for numbness, tingling, burning, anything that would be consistent with carpal tunnel. So we wouldn't want to see any of that. Okay, and then the Tinel test. And this is where you take your finger and you percuss lightly over the medium nerve on the inner aspect of the wrist. This is on 2421B in your book, page 547. The client should have no tingling or shocking sensation. If they do, then that also could indicate that the medium nerve is entrapped in the carpal tunnel, and that results in pain, numbness, and impaired functioning of the hand. So again here, this slide is pretty explanatory. We're inspecting, we're palpating the size, the shape, the color, looking for any swelling, any range of motion, any problems with repeating the maneuver when we do it against resistance. Hips, also looking at symmetry, shapes, the thoracic curve, the lumbar curve, how stable is it? Is there any tenderness, any crepitus? Do we have good range of motion with and without resistance? And then here we'll also do the Lezique test or the straight leg raising. The knees, we're doing inspection and palpation. Again, looking at the shape, the symmetry, the swelling, the deformities, the alignment. We'll have the client sit with the knees dangling. Again, palpate for tenderness, warmth, consistency. The bulge test. So again, that's where you're rubbing it and you're looking for small amounts of fluid to determine if the swelling is tissue swelling or fluid. The ballottement test, where you look for large amounts of fluid. And then the range of motion, and we're also testing for pain and injury here. Then we're evaluating the ankles and the feet with the client sitting, standing, walking. We're looking at the position, the alignment, the shape, and the skin. The toes should be pointing forward and lying flat. We want to make sure that the toes and feet are in alignment with the lower leg. Also, the skin should be smooth, free of corns and calluses. And then we want to make sure that they have a nice arch, that the weight is bearing on the foot midline. Any sort of deviation in the great toe, any sort of bunions, things like that, we would want to take a look at. We're also palpating the ankles and the feet for tenderness, heat, swelling, or nodules. Any bony promises, nodules, or crepitus in the interphalangeal joints. This can happen if someone has things like gouty arthritis or rheumatoid arthritis. We're looking at the metatarsophalangeal joints by squeezing the foot from side to side and palpating the metatarsals, looking for any tenderness. We're looking at the plantar area, making sure there's no pain or tenderness there. And then perform the squeeze test by squeezing the middle of the foot with your hand across the top of the foot to rule out any sort of rheumatoid arthritis or psoriatic arthritis. Then we're testing the range of motion. We're having those clients point those toes upward for dorsiflexion and downward for plantar flexion, turning the soles outward for eversion, inward for inversion, rotating outward for abduction, inward for adduction, and then the toes under the foot for flexion and upward for extension. We're also looking to see if they're able to do it against resistance. If someone needs I would take a careful look at this slide. This is Ottawa ankle rules for x-ray referral. So if these conditions occur, you would want to make sure that the client gets evaluated immediately with an x-ray. So inability to bear weight immediately or during the exam for the ankle. Any sort of pain around the malleolar area, bone tenderness at the tips or the edge of the lateral malleus. Foot x-ray indicators pain in the midfoot and bone tenderness at the bone of the fifth metatarsal or navicular bone, and then inability to bear weight immediately or during the exam. Okay, next up is validating our assessment data. So you're going to want to make sure that you put all the data together, form your cues, your inferences, analyze it, put everything that's alike together, and then verify it. Make sure it's reliable and accurate. Again, you can use the client's statements that you gathered, the cues that you gathered, the chart, other doctors, family members. Then you're going to document your assessment data. So cold spa, okay, the characteristics, the onset, the location, the SPA, the situation, the background, assessment, recommendations. So here we're analyzing our data and we're forming those clinical judgments, okay? Opportunities to improve the health in these clients, we want to think about. Okay, so opportunity to improve health would be learn better ways to exercise to improve the health. They're at risk for trauma to the wrist because of the repetitive movements, whether it be job or recreational related. Risk for injury associated with severe advancing osteoporosis. Risk for injury to joint muscles or bones related to environmental hazards in the work environment. Risk for disuse syndrome. Risk for urinary retention associated with urine stasis secondary to immobility. And then some actual client concerns here. Poor physical mobility associated with impaired joint movement, decreased muscle strength or fractured bone. Inability to tolerate activities associated with muscle weakness or joint pain. Constipation associated with decreased gastric motility and muscle tone secondary to immobility. Impaired sexual activity associated with lower back pain. And there's a few others. So you'll find those on page 566 in your book. All right, what are some of the collaborative problems that we'll see? So collaborative problems could include risk for complication of osteoporosis, joint dislocation, compartmental syndrome, and pathological factors. So if they develop these, you're going to need collaboration from the physician. Osteoporosis, you'll probably need some scans, some medications. Joint dislocation, again, scans, and possible relocating the joint and therapy. Compartmental syndrome, here you probably have to remove the cast or whatever's causing the nerve to be damaged there. And then, of course, pathological fractures. How can we move these clients without doing further damage? What can we do to help prevent them from developing additional fractures and other complications? And then some medical problems, that they might develop All right, you're going to make sure that you refer these clients out for treatment. So they might develop kyphosis, lordosis, scoliosis. Also, they have ankylosing spondylitis. So this would be a combination of things. This ankylosing spondylitis is an inflammatory disease, and it can cause some of the bones in the spine of the vertebrae to fuse, and that fusing makes the spine less flexible and also can cause them to become hunched over. Sometimes it can affect the ribs and affect their ability to breathe. Which test is being conducted in this figure? So this would be the Fallon test. All right. So what is osteoporosis? Osteoporosis is a disease that weakens your bones, making the bones thinner and less dense. Some people are more prone to it. Your bones are usually dense and strong and should absorb most impact, but as you age, the bones will lose some of their density and the ability to regrow or remodel themselves. You also have a decrease in those osteoblasts that help you develop that new bone. All right, so your bones become fragile and weak, and most people don't even know they have it until they have a break or a broken bone. It can make any of the bones break, but the ones most likely to break are going to be the hips, the wrists, or the spine. So more than 200 million women are affected worldwide. The bone starts to demineralize, becomes porous and fragile, and at risk for fractures. It happens silently and progressively. The most common fracture sites, again, are the spine, the wrist, and the hip. And we do screen. We screen women age 65 and older, women that are post-menopausal, that are under the age of 65, or who have a fracture risk that is the same or greater than those that are already 65. And then any white woman who has no additional risk factors. So here we have a list of the basic risk factors. Ones that are not modifiable are age, being of female gender, ethnicity, family history of osteoporosis, having previous fractures, menopause, hysterectomy, long-term steroid therapy, rheumatoid arthritis, and then primary or secondary hypogonadism in men. Some of the modifiable risk factors would be things like alcohol intake, smoking, low BMI, poor nutrition, vitamin D deficiency, eating disorders, low dietary calcium intake, insufficient exercise, and frequent falls. So risk factors for the fracture include being of 65 years old or older, a vertebral compression fracture, fracture with minimal trauma after the age of 40, a family history of osteoporotic fracture, long-term use of steroids, medical conditions, primary hyperparathyroidism, a tendency to fall, spinal fractures apparent on an x-ray, hypogonadism, early menopause, rheumatoid arthritis, hyperthyroidism, low body weight, and low calcium intake, excessive alcohol, smoking, and low mineral density. Now, for the low body weight, if the present weight is more than 10% below the weight at age 25, also a cause or a risk factor. So we need to teach parents how to help their kids. So we want to make sure that they take a nutritious diet with adequate calcium. Avoid protein malnutrition or undernutrition. Maintain the adequate supply of vitamin D. Regular physical activity. And avoid the effects of secondhand smoke. To prevent bone loss, we want to make sure that we have adequate calcium intake. Don't allow yourself to be malnutritious or not eating enough nutrition. Any sort of severe weight loss diet or eating disorder could contribute to the development of this. Maintain an appropriate and adequate supply of vitamin D. Participate in regular weight-bearing activities and avoid active or secondhand smoking and heavy drinking. All right, so here we have from your book on page 568 some abnormal spinal curvatures that we might see in people. Thoracic kyphosis, lordosis, and scoliosis. Flattening of the lumbar curvature. Flattening of the lumbar curvature might be seen with someone that has a herniated lumbar disc or if they developed ankylosing spondylitis. For lumbar hyperlordosis, this is caused by hip flexion contracture and hip extensor weakness, and this can be caused by the lumbar spine being driven into the increasing lordosis and balancing the head over the pelvis. So these clients may need to use their hands for stability here. Kyphosis, this is where we have a rounded thoracic convexity. And then scoliosis, we have this lateral curvature of the spine with an increase in convexity on that side that is curved and is seen in scoliosis. And then the ankylosing spondylitis, we have clinical manifestations of that, and this is where the vertebrae are fusing together, so it's going to affect their ability to move. So the first picture is the flattening of that lumbar curvature, which you might see with that herniated disc. The lumbar hyperdosis. You see he's stabilizing himself with his hands there. Picture of the kyphosis and the ankylosing spondylitis. Here we have the scoliosis and the ankylosing spondylitis again. And then some abnormalities commonly associated with the upper extremities. Okay, this acute rheumatoid arthritis. So here on the left, you see tender, painful, swollen, stiff joints that are seen in acute rheumatoid arthritis. Boutonniere and swan neck deformities seen in chronic rheumatoid arthritis. We have flexion of the proximal interphalangeal joints and hyperextension of the distal interphalangeal joints. Boutonniere deformity and hyperextension of the proximal interphalangeal joints and flexion of the distal interphalangeal joints, called a swan neck deformity. The person can also develop ganglion cysts, which are these non-tender, round, and large, swollen, fluid-filled cysts. These are usually seen around the wrist area. And then osteoarthritis or DJD nodules on the dorsolateral aspects of the distal interphalangeal joints, called Herbedian nodes. And these are caused by these overgrowth of bones from the osteoarthritis. They're usually hard and painless, but they can affect middle-aged or older adults. And then the tenosynovitis or Burkitt nodes, these we'll see, and it'll cause painful extension of the finger and infection of the flexor tendon sheaths. The thenar atrophy, and this is atrophy of the thenar prominence due to pressure on the median nerve. That's seen like in carpal tunnel. On the left there, you see the chronic rheumatoid arthritis leads to these, it leads to both conditions. On the left, it leads to the boutonniere deformity. And on the right, you see the swan neck deformity. Looks almost like its name. Then the ganglion cysts we talked about that are mostly on the wrist, and the tenosynovitis. The osteoarthritis with the Herbadita nodes and the Bouchard nodes. You may see pictures of this, and they may ask you to tell them what it is. Gouty arthritis. And then, of course, the callus on the feet. So now we're talking about things that affect the feet and the toes. We saw the picture of the acute gouty arthritis. And on this, the great toe is tender, painful, red and hot, and swollen. This can be affected by diet. You'll see this a lot with diabetics. The flat foot where there's no arch, and this can cause pain and swelling of the surface of the feet. The callus you saw earlier, that was a painful thickened area of skin at the pressure point. And then the hallux valgus, this is an abnormality where the great toe is deviated laterally and it can overlap the second toe. It can become inflamed, painful, and bunions can form on this. And then the corn, these are painful thickening of the skin that occur over bony prominences and at pressure points. The hammer toe, which is caused by hyperextension at the metatarsal joint, phalangeal joint, with flexion at the proximal interphalangeal joint, known as hammer toe. This happens a lot with the second toe. The plantar wart, these are painful warts that occur underneath the callus, and they look like dark, tiny spots. So following statement, true or false? Calluses are painful thickenings of the skin that occur over a bony prominence at pressure points. That's false. They are non-painful areas of thickened skin that occur at pressure points. Corns are painful thickenings of the skin that occur over bony prominences and at pressure points.